Let's talk headaches, the kind that stop people in their tracks, make them cancel plans, turn off lights, and wonder if their skull might actually split open. And no, I'm not talking about the kind from missing your morning coffee. I mean real, clinical, stop-you-in-your-tracks headaches. Migraines, clusters, tension, arteritis. Each of them has its own story, and if you're going to take care of patients or yourself, you've got to know the difference. Let's start with migraines. These are neurologic events, not just really bad headaches. They're caused by a wave of hyperexcitable activity across the cortex called cortical spreading depression. This activates pain-sensitive fibers in the meninges and involves neurotransmitters like serotonin and calcitonin gene-related peptide, CGRP for short. When that chemical storm hits, the pain is real. Migraines usually come in 4 stages. First, the premonitory phase. More than 80% of adults with migraines can feel it coming, sometimes hours or even days before. They might get irritable, tired, crave weird foods, or suddenly want to be alone. They might start peeing more, have diarrhea, or get constipated. These symptoms are thought to be linked to dopamine levels in the brain. Most people who get migraines have the same premonitory symptoms each time. Next is the aura phase, and not everyone has this one. Only about 30% of people with migraines experience an aura. This can look like flashing lights, zigzags, or bright spots in the visual field, usually affecting 1/2 of the vision. Some people feel numbness or tingling in their lips, face, or hands. Others feel dizzy, confused, or slightly weak. This used to be blamed on blood flow changes, but we now know it's more of a nerve function issue than a circulation one. Then comes the headache phase. This is the big one. It's often one-sided, pulsating, and absolutely debilitating. People with migraines often can't stand light, sound, or even touch, something called allodynia, which means even a light breeze can feel like sandpaper. Nausea and vomiting are common. This phase can last anywhere from 4 hours to 72 hours. And finally, the postdrome. The pain might be gone, but most patients don't just bounce back. They're tired. Their brain feels foggy. Their mood's off. Their scalp and neck might still feel sore. And often they just want to sleep. Now let's talk about triggers. Everyone's different, but some common ones include hormone changes, stress, skipped meals, lack of sleep, dehydration, bright lights, strong smells, and certain foods. Red wine, chocolate, aged cheeses, nitrates, MSG, and artificial sweeteners can all play a role. Patients need to know their own patterns. When it comes to treatment, we divide it into 2 categories, abortive and preventive. Abortive medications are meant to stop the headache once it's already started. First line, triptans. These are the go-to drugs like sumatriptan and rizatriptan. They work best if taken early, and they can relieve symptoms in as little as 20 to 60 minutes. But they're not for everyone. Triptans are contraindicated in people with ischemic heart disease, and they can raise blood pressure. They also come with side effects like drowsiness, muscle pain, sweating, and anxiety. And here's the big warning. Never combine triptans with ergotamine. Speaking of ergotamine, that's another abortive option. It comes in all kinds of forms: oral, sublingual, injectable, rectal, even inhaled. It's cheap and effective if taken early. It works by causing prolonged constriction of cranial blood vessels. Side effects can include muscle aches, numbness and tingling, nausea, and vomiting. Often, we give an anti-nausea med alongside it. Again, don't take it with triptans. It's a recipe for a prolonged vasoactive reaction. Other abortive options include NSAIDs, antispasmodics, and neuroleptics. Neuroleptics can be used alone or in combination with other meds depending on the situation. Now, if a patient gets frequent migraines, they might need preventive treatment. This is where we bring in medications like beta blockers, anti-epileptics, antidepressants, ACE inhibitors, and ARBs. There's also a newer class of meds, CGRP monoclonal antibodies. These include aranimab, fremanezumab, and galcanezumab. They're FDA approved and can make a huge difference in preventing migraines altogether. All right, that's migraines. Let's move on to tension headaches. These are the ones most people think of when they say, "I've got a headache." It's a steady, squeezing pain, often described as a band around the head or a weight on top of it. It usually starts in the forehead, temples, or the back of the neck. Unlike migraines, tension headaches don't come with nausea or light sensitivity. They're mostly caused by stress, muscle tension, or fatigue. Next up, cluster headaches. These are rare but intense. They're called cluster headaches because they come in groups, often several times a day for weeks at a time. They're always one-sided and usually centered around the eye or temple. The pain is sharp, stabbing, and sudden. Each episode lasts from 15 minutes to 3 hours. You'll often see symptoms like eye watering, nasal congestion, and even drooping of the eyelid on the affected side. Treatments include 100% oxygen by face mask, subcutaneous sumatriptan, or intranasal zolmitriptan. Finally, cranial arteritis. This one's more common in older adults and can be serious. It usually starts with vague symptoms like fatigue, fever, weight loss, or malaise. But as the arteries in the scalp become inflamed, you may see redness, swelling, tenderness, or pain over the temporal artery. Sometimes the artery looks swollen or nodular. The big concern here is vision loss due to vascular occlusion. Treatment includes high-dose corticosteroids started early and tapered slowly. Patients should never stop these meds abruptly. Doing so could trigger a relapse. Analgesics can help with pain. Let's talk about nursing management. First, your job is to relieve the pain. Individualized care matters. If it's a migraine or cluster headache and the patient catches it early, we start with abortive meds immediately. Don't delay treatment while trying non-drug methods alone. During an episode, keep the lights off, keep the room quiet, elevate the head of the bed to 30 degrees, and treat the symptoms like nausea or muscle tightness. For tension headaches, heat and massage can help. Medications might include analgesics, antidepressants, or muscle relaxants. And then there's education. Patients need to know what's going on in their own body. Teach them to identify their triggers and stick to a routine. Regular sleep, regular meals, hydration, and stress management. Things like meditation, biofeedback, and light exercise can help too. Don't forget to provide reassurance. Many patients fear their headache might be something more serious, like a brain tumor. Clear communication and support can go a long way. And finally, connect them with specialists when needed. The National Headache Foundation and the American Headache Society can help patients find providers who understand what they're going through. So whether it's the silent creep of a migraine aura or the stabbing jolt of a cluster attack, every headache tells a story. As nurses, we listen closely and then we do something about it.